and welcome to our presentation on the burden of malaria in Sub-Saharan Africa. My name is April Heitzman. Other presenters are Katie Newell and Bedit Escalara. Sub-Saharan Africa consists of all of the countries on the continent of Africa lying fully south or partially south of the Saharan Desert. The United Nations Development Program recognizes 46 countries to be sub-Saharan. I included a map on this slide just so that you could see how many countries and how much of the continent of Africa is technically considered sub-Saharan. Malaria is endemic in sub-Saharan Africa. 300 to 600 million cases and more than 1 million people die per year globally. 90% of these cases are in sub-Saharan Africa. Over $12 billion per year is calculated in direct costs. Those costs are things such as diagnosis, treatment, and the cost of early death. Each country affected is going to see a 1.3% suppression of economic growth per year. Malaria is caused by a parasite. Most common ones are here Plasmodium malariae, Plasmodium ovale, Plasmodium vivax, and Plasmodium falciparum, which is the most common and the most deadly. It is a vector-borne illness transmitted by Anopheles mosquitoes. Anopheles mosquitoes thrive in sub-Saharan Africa. It can also be spread human to human via blood transfusion with an infected patient or an organ transplant with an infected patient. It can be spread by sharing needles, or more commonly, the human-to-human spread is going to be congenital, so that's mother to infant in utero. The incubation period of malaria is anywhere from 7 days to 4 weeks post-infection. It can be as late as 1 year. Plasmodium vivax and Plasmodium ovale can relapse, so the parasite can remain dormant in the liver for up to 4 years after infection, but still continue to make a patient sick. I've included a graphic here of the malaria transmission cycle. So it starts out at the top with the Plasmodium sporocytes, which is the parasite, that infects the first vector, which is a mosquito. The mosquito then bites the initial human host, infecting that human host. The parasite travels to that patient's liver, where it infects more of the red blood cells and attacks more of the red blood cells. If that patient is then infected person, is then bitten by a second mosquito, and this mosquito could be healthy and without the disease, then that mosquito will pick up the parasite, and then that is the second vector which will pass it on to the next human host. Over here next to the initial human host, there's also another track which just shows that a mother could pass it on to her baby in utero. Who is affected by malaria? People living in areas where malaria is endemic, so everyone in sub-Saharan Africa, and especially people with low immunity. So children are especially susceptible to this. Travelers with no immunity, and the immunocompromised, so anyone who's got HIV or tuberculosis or any other comorbidities. And then also pregnant women are more often affected and more at risk for malaria. The symptoms of malaria are flu-like symptoms. So you have the high fever, shaking, chills, headache, muscle aches, fatigue, nausea, vomiting, diarrhea, and jaundice. They're at the bottom. And with the exception of the jaundice, most of these symptoms you could receive from another type of a virus or illness that isn't necessarily as serious as malaria. So you can see that maybe with some of these symptoms, people wouldn't be rushing right to the doctor to get help, or thinking that they have a serious disease that needs to be diagnosed and treated rapidly. Diagnosis and treatment. The diagnostics are done by a blood test. It's a blood smear. Then it's tested under a microscope, and the Plasmodium parasites are seen under the microscope. There's also the option of a rapid diagnostic test or an RDT, and these are available in kits. They use either a dipstick or a cassette, and these are great for areas where the microscopy is not available. Treatment of malaria is dependent on many factors. The type of species is important, so which type of Plasmodium parasite. Also, the area acquired is important because that will tell you if you've acquired it in an area where there's a lot of resistance to the drugs used. They need to know that, and they can come up with a treatment combination that will hopefully help. Also, your clinical status is very important. So really, how sick is the patient? What are the symptoms? How far has this illness developed? Comorbidities are important as well. So if the patient has any other illnesses such as HIV or tuberculosis. Pregnancy, if a patient's pregnant, they can't take certain medications. And then also any allergies or any other medications they're taking are just important factors when coming up with a plan to treat the malaria. I've listed many of the drugs used here. You can see there are a lot of them, and a lot of these drugs are used in combination with others to come up with the right treatment based on all of these other factors. Risk factors, because it's a vector-borne illness, you have risk factors from humans, mosquitoes, the vector, and also the environment. So risk factors that are related to humans are health status, pregnancy, and age. And typically, young children are more susceptible to becoming very, very ill. And it's more deadly for young children because they haven't had any time to build up a strong immune system, and they haven't had any time to build up stronger immunities to malaria. The older a person is that has lived in an endemic area, the more chances they've had to build up immunity to it. I believe 90% of the deaths are children under the age of 5. So, other risk factors that are related to the vector, the mosquito, are insecticide resistance and breeding sites. So, basically with the insecticides, you're just trying to kill or keep out the mosquitoes, and the breeding sites are in water. So the availability of standing water is very, very important for them to continue to breed. And environmentally, we have rainfall. Again, those breeding sites are very important, so a lot of rainfall is good for those mosquitoes. Poorly constructed housing, that basically just allows more routes for mosquitoes to get inside the house and bite people. So you've got housing that maybe there's no screens on the windows, the doors are left open all the time to get a breeze. You've got maybe holes or slits in the walls or in the floors. That just allows opportunities for mosquitoes to get into the house. Poor drainage, again, dealing with those breeding sites. Limited access to healthcare and temperature. So the ideal temperature for these mosquitoes to thrive is between 75 and 85 degrees. So next up, Katie is going to discuss cultural, economic, and environmental contributions to this issue.
Thank you, April. I'm now going to answer 3 questions in regards to malaria in sub-Saharan Africa. The first question being, what do culture, economy, and environments contribute to the problem? A country's religious beliefs may play a part in when they decide to seek intervention for that disease. Poorer cultures, such as sub-Saharan Africa, are more likely to contract malaria because of the deprivation involved with living in a poorer community. They have less access to adequate health care, safe living conditions, clean water, sanitation, and education. Studies that have been done in poorer countries, such as sub-Saharan Africa, have proved that health staffs are also reluctant to work in rural and more remote health centers, which also attributes to the lack of access to health care that can be seen in these more rural communities. Still today, many sub-Saharan African people refuse to sleep under mosquito nets, which is a simple solution that could save thousands of lives. A lot of this has to do with their religious beliefs in regards to using healers instead of healthcare professionals, and things such as praying away diseases and using local herbal remedies and animal remedies in order to treat their diseases. Poorer, less educated countries have more trouble obtaining preventative tools in order to avoid the possibility of disease, which goes back to the mosquito nets that I was just talking about. Poor households living in rural areas spend significantly less on all forms of malaria prevention compared to their richer counterparts, including bed nets and insecticides. Thus, preventative measures might be missing in poorer individuals and households that face greater exposure to malaria than those that are better off. Information, education, and communication material for malaria might not reach poor people. This has a lot to do with the fact that because these people are living in more rural areas, they have a lot less access to education, and this can cause people to be illiterate. They can't read, they can't write, and these people with lower levels of education are unable to understand written health education materials such as posters and flyers, so they don't know about the preventative measures and the options and the things that they have that could help prevent this disease. Poor households also most likely don't have access to radios or television, which means they could miss health messages that are broadcast through the media. In regards to environment, I found a great quote that describes exactly how malaria is spread and what the environment is doing to help spread the disease. Quote, "Climate, local ecology, and active control affect the ability of malaria parasites and their mosquito vectors to coexist long enough to enable transmission. The frequency of transmission depends on the density and infectivity of anopheline vectors. These features depend on a range of climatic, physical, and population characteristics. For example, rainfall, location of human settlements near or at rivers, or other mosquito larval breeding sites, and the density of human populations in a village. The most significant determinant of the intensity of parasite transmission is climate." End quote. This brings us back to me saying that a lot of rural Sub-Saharan African citizens don't have access to clean water, and because of this, their villages tend to settle near rivers or at rivers where they are able to get water. This settlement location, coupled with the heat and the extreme climate of Sub-Saharan Africa, make it a perfect place for mosquito vectors that are carrying malaria to transmit that disease. The next question I'm going to answer are, what are the health, economic, and social consequences of the problem? Some of the health consequences of malaria in Sub-Saharan Africa include that more than 90% of the world's deaths due to malaria occur in Sub-Saharan Africa. An estimated 58% of malaria deaths occur among the poorest 20% of the world's population. In 2016, an estimated 445,000 people died of malaria. Most were young children in Sub-Saharan Africa. In areas with high transmission of the disease, such as Sub-Saharan Africa, the most vulnerable are those with fragile immunity, which mostly consists of young children as well as pregnant women. Some of the economic consequences of malaria include: malaria is responsible for employee absenteeism, increased healthcare spending, and decreased productivity, all of which can negatively impact a company's reputation. In Sub-Saharan Africa, 72% of companies reported a negative malarial impact, with 39% perceiving these impacts to be serious. Overall, households in Africa lose up to 20% of their income due to the disease. In more rural areas, this 25% can be contributed to the idea that because they have less access to education, them being sick with malaria is causing them to lose out on the access that they do have to malaria, which is making them grow up with no education at all, which is helping to contribute to that 25% of lost income. Leading economics also estimate that malaria causes an economic growth penalty of up to 1.3% per year in malarial endemic African countries. Malaria discourages investments in tourism, affects land use patterns and crop selection, resulting in suboptimal agricultural production, reduces labor productivity, and impairs learning. A few more economic costs include that malaria can strain national economies, which impacting some nations' gross domestic product by as much as an estimated 5 to 6%. In some areas, malaria accounts for 15% of health-related absenteeism from school. This goes back to me relating this to its overall income loss of 25% per African family. It is estimated that in endemic areas, malaria may impair as much as 60% of the school children's learning ability. Overall direct costs for malaria have been estimated to be at least $12 billion per year. Some of the social consequences of malaria in sub-Saharan Africa are limited knowledge of the appropriate treatment, which goes back to me talking about their lack of access to healthcare and health education, their lack of access to television and radio broadcasts that broadcast health messages, and their inability to read posters and flyers. Another social consequence is gender. Women are most likely to contract malaria than men because they are typically less educated, and pregnant women have decreased immunity. Inability to access preventative measures because of costs or accessibility. Many sub-Saharan African villages don't have access to preventative measures or healthcare at all. These diseases constrain the health and development of children, often impacting their education and therefore making it more difficult for them to learn later in life. These children who grow into adults with less education then see lower levels of productivity. Pregnant women who contract malaria are at risk of giving birth to low birth weight babies. A few more social consequences include costs to individuals and families and costs to government. The costs to individuals and families include purchase of drugs for treating malaria at home, expenses for travel to and treatment at dispensaries and clinics, lost days of work, absences from school, expenses for preventative measures like mosquito nets and insecticides, and expenses for burial in cases of death. The costs to the government include maintenance, supply, and staffing of health facilities, purchases of drugs and supplies, public health interventions against malaria, such as insecticide spraying or distribution of insecticide-treated bed nets, and lost days of work with resulting loss of income and lost opportunities for economic ventures and tourism. The last question I'm going to answer is what global health initiatives are available to address the problem? Some of the more straightforward interventions and initiatives are prompt treatment of those infected based on a confirmed diagnosis. So they need to be seen by a healthcare professional who can diagnose them with malaria, who is then able to treat that malaria right then and right there. Another initiative is preventative therapy for pregnant women, insecticide-treated bed nets, indoor residual spraying of homes in malarial zones, and the President's Malaria Initiative, which is an initiative designed by the U.S. to reduce deaths from malaria in sub-Saharan Africa. This initiative was passed back in 2005 when President Bush pledged to increase U.S. funding for malaria treatment and prevention to $1.2 billion over 5 years, which, when you think about the overall cost of malaria being $12 billion, it's not much, but it is something. The updated President's Malaria Initiative reaffirms support for a long-term goal of worldwide malarial eradication and aims to build on progress made in the last decade and address new challenges that could hamper further diagnosis. Thank you for listening to me answer these 3 questions. After this, I'm going to pass it off to Baidi, who is going to conclude our presentation.
Thank you, Katie. Hi, everybody. My name is Bailey Escalera, and I will be addressing our last two questions. The first of which is, what gaps are found in the existing initiatives that Katie spoke about? And I'll just go over them again. Prompt treatment of those infected, of those based on a confirmed diagnosis, preventative therapy for pregnant women, insecticide-treated bed nets, indoor residual spraying of homes in malarial zones, and the PMI, Presidential Malaria Initiative. First, we'll go over the gaps found in prompt treatment of those infected based on a confirmed diagnosis. A critical step in reducing the infection burden of disease is missing, which is that current tests cannot detect either the low level blood stage infections of malaria species or the dormant liver stages of P. vivax and P. ovale. A highly sensitive point-of-care field test is needed to rapidly detect low-density parasitemia and identify all infected individuals, enabling immediate treatment. Gaps in preventative therapy for women. In high-burden countries, intermittent preventative treatment in pregnant women, or IPTP, noticeably lags behind other malarial control measures. There's a lack of training and supervision and opportunities for healthcare workers, resulting in poor knowledge of IPTP guidelines and uncertainty about the safety and efficacy of both patients and health workers. There's also a source of data inaccuracy along the data recording and reporting chain, limiting policy makers' ability to react adequately to trends and challenges. Inconsistently offered in health facilities, leading to some women being denied services. Gaps in insecticide-treated mosquito nets. Ownership coverage of long-lasting insecticide-treated mosquito nets was lagging behind the national and global targets in the study community because of low access rate with a relatively wide intra-household net coverage gap. There's a wide gap between ownership of the nets and the actual use. The LLIN use was hampered by lack of ownership and, most importantly, by behavioral-driven gaps. These behavioral-driven gaps, as pointed out here on the last point, can be due to the shape of the nets or sleeping arrangements within the homes, low risk perception, so some people don't actually think that these nets will help them very much in preventing malaria, or they save the nets for future use or for other uses, or there's simply insufficient access to long-lasting insecticide-treated mosquito nets. Or they have, as I mentioned, they use the nets for unintended purposes. Gaps in indoor residual spraying. Many Sub-Saharan African population portrayed IRS as having limited efficacy. The factors for refusal of these sprayings in their homes is due to not understanding fully of the IRS. The community leader level of support is not all there. Characteristics of the IRS program implementation are not fully understood. And there's environmental, political, historical factors, and also lack of solidarity within the population about the IRS. So if most of the population doesn't believe in the indoor residual spraying, then that leads to less of this, letting them come into their home and spray their home. Barriers to acceptance. Selection and performance of spray operators, negative experiences from previous campaigns, political conflicts, difficulty in removing heavy or numerous household assets in order to have their home sprayed, and preference for insecticide-treated nets over the actual spraying. Gaps in the President's Malaria Initiative. The PMI operates in 24 focus countries in Africa and supports 3 programs in Southeast Asia, protecting nearly 500 million people from malaria each year. The current Trump administration has proposed to reduce malaria funding for 2020. That's an estimated 171 million. Reductions in funding for PMI could lead to a large increase in the number of malaria cases that we have seen, and even those in the countries where malaria is very low, they could also see an increase on that. If funding is maintained, PMI-funded interventions are estimated to avert a further 162 million cases, saving a further 692,589 lives up until 2020. The next question that I want to address here are, what few priority steps do you recommend to address gaps found in the existing initiative and their costs? And what are their costs? So first we're going to address what I would recommend how to address the gap in treatment of those infected based on a confirmed diagnosis. Diagnosis by microscopy would be an inexpensive way, and in a well-established healthcare center would be their most proficient form with well-trained staff. On average, 39 of the cost of diagnosing a case of malaria was attributable to the diagnostic technique and 42% to personnel and training. The median financial cost of diagnosing a case of malaria was $4.32. The cost of diagnosis and treatment will also be dependent on parasite prevalence. Addressing gaps, preventative therapy for pregnant women. And, the World Health Organization recommended that all health ministries and donor agencies scale up the distribution of ITNs, especially to target population of small children and pregnant women, since they are the population most at risk. Improvements will require consistent provision of the implementation efforts of the current WHO intermittent preventative treatment in pregnant women policy recommendations. Also, provision in supplies or management of supplies to the private sector should be revised. The availability of clear guidelines and as well as improved training and supervision for healthcare workers. Improving facility and district level recording and reporting will further strengthen the country's ability to address uptake of IPTPs. And here's the median cost, which is $2.06 for IPT in pregnant women. And addressing the gaps in insecticide-treated mosquito nets. Although the insecticide-treated nets, or the ITNs, at present cost only $2, these require regular retreatment every 6 to 12 months. What I would suggest is new technology of the long-lasting insecticidal nets, the LLINS, that should be more widely distributed. It'll eliminate the need for retreatment of the regular ITNs. The new technology of the long-lasting insecticidal nets would cost $5 to $6 at present time. Addressing gaps for indoor residual spraying, or IRS. Despite positive perceptions towards IRS, only 26.7% of the respondents have sprayed their houses, which is lower than the WHO targeted coverage. And this really low respondents is due to respiratory disorders and headaches, food and contamination, discoloring inner house walls, difficulty in furniture movement, and unpleasant odor in their home. Abdul Hussein and associates conducted a study where they concluded IRS campaign accompanied with education for behavioral change should be considered to ensure householders' participation and cooperation in the IRS program. Additionally, clear communication and engagement with community leaders during spray operator selection and spray implementation may help reduce barriers to IRS acceptance. The median financial cost per person protected by the IRS was about $3.91. Addressing the gaps for President's Malaria Initiative, the PMI. The PMI administration is requesting $200 million in additional resources to bring a total U.S. funding to $874 million. This includes $71 million in new funding and $129 million via redirected Ebola funding. Expand programs in 4 countries. This would allow them to expand programs in 4 countries in West Africa, which is about coverage for about 70 million additional people. Accelerate research, development, and evaluation of new malaria tools focus on better diagnostics, vector control, and medicines. This will procure 13.7 million insecticide-treated bed nets. Here are all of our references that I have gathered together. Thank you so much for listening.